Good afternoon, sir. I am going to discuss about evaluation of primary aldosteronism syndrome. My moderator is Dr. Professor Sharma, sir.
Not evaluation, evaluation. You understand? Evaluation ante chinna bedda peddaga avadam.
Yes, sir.
Evaluation ante danini investigate cheyuta. Okay. Evaluation of primary aldosteronism. Okay.
Introduction. Mineralocorticoid production is mainly controlled by the renin aldosteronism regulatory cycle, which is initiated by the release of renin from the juxtaglomerular cells in the kidney, resulting in the cleavage of angiotensinogen to angiotensinogen 1 in the liver, and angiotensinogen converting enzyme cleaves angiotensin 1 to angiotensin 2, which then binds and activates the angiotensin 2 receptor type 1, resulting in increased adrenal aldosteronism production and vasoconstriction.
So what did you understand by this?
Mainly it is regulated by renin angiotensin aldosterone cycle, which is initiated by the release of renin from the juxtaglomerular cells, which are present in the kidney, and in the liver it converts angiotensinogen into angiotensinogen 1 by renin, and then converts into angiotensin 1 into angiotensin 2 by asin and converting enzyme, and which then binds into the angiotensin type 2 receptor, which result in increase of adrenal aldosterone production and vasoconstriction, sir. It mainly depends upon the arterial pressure and renal blood flow, sir. Aldosterone enhances sodium retention and potassium excretion and increases the arterial perfusion pressure, which in turn regulates the renin release. And because mineralocorticoid synthesis is primarily under the control of renin angiotensin aldosterone system, hypothalamic pituitary damage does not significantly impact the capacity of adrenal to synthesize aldosterone.
That's what we learned.
Yes,
so basically there are three hormones coming out from the adrenal cortex: the mineralocorticoids from the glomerulus, and the fasciculata from giving the cortisol, and reticularis giving the steroids. Out of which only the cortisol is directly under the control of the ACTH, which is under the control of the hypothalamus CRH. Whereas the mineralocorticoid is not directly under the influence of the ACTH. That is why we learned that whenever there is a secondary involvement of the pituitary as a cause of deficiency, mineralocorticoid deficiency doesn't occur. It is only the glucocorticoid that occurs. That's what we have learned. So, what is it that feedback controls the mineralocorticoid? RAS. RAS is the one which controls that. So, it is out of the pituitary control in general, but there is a condition where pituitary can produce hyperaldosteronism. We'll come to that a little later. Okay.
If mineralocorticoid excess is present, there will be a counter-regulatory down-regulation of plasma renin, and conversely, in mineralocorticoid deficiency, plasma renin is markedly increased. Physiologically, oral or IV sodium loading results in suppression of aldosterone, a response that is attenuated or absent in patients with autonomous mineralocorticoid excess.
Normally, what will happen whenever there is excess of mineralocorticoid, that is aldosterone is there more in the body, then reflexively the renin is suppressed, and aldosterone is less, the renin is more. So when we load physiologically, you load IV sodium, and that suppresses the aldosterone, because aldosterone is salt retaining hormone at the level of the kidney, and when you have salt infused, the kidney will not try to retain the salt, and aldosterone is reduced. This is a normal response, but that is attenuated or absent in patients who have excess mineralocorticoid, which is not controlled by anything, autonomous mineralocorticoid axis. This is from Harrison. You tell.
Yes, sir. This is when there is an increase in, say, circulatory volume and renal perfusion pressure increases, then there will be a secretion of renin from the juxtaglomerular cells, and which converts angiotensinogen into angiotensinogen 1 in the liver, and angiotensinogen 1 to angiotensinogen 2 by the angiotensin converting enzyme, that is ACE enzyme, and in turn activation of angiotensinogen 1 type 2 receptors, and which results in secretion of aldosterone from the adrenal medulla, and it in turn leads to retention of sodium and excretion of potassium.
So the point here that we need to know is there is the kidney, and on the top of that is the adrenal. There is the juxtaglomerular apparatus which is nearer to the proximal canalicular tubule, and that has got the potential to secrete the an enzyme called renin. This is the protein. This renin protein is produced whenever the perfusion pressure is reduced. This is the glomerulus, let us say, and this is the glomerulus, and there is an afferent tubule here, and then there is all this one is there, and then the efferent. So this is the tubule, renal tubule. So if the perfusion pressure in the afferent arteriole is reduced, and the juxtaglomerular apparatus, that is the proximal PCT, and there is a macula densa there, and juxtaglomerular apparatus, that is stimulated by the afferent arterial pressure. When the renal perfusion pressure, which is the afferent arterial pressure, is reduced due to some reason, then automatically there will be increase in stimulation of the juxtaglomerular apparatus, and that produces renin, which is an enzyme which converts angiotensinogen, which is a sort of hormone that is converted into angiotensin 1. Angiotensinogen is converted into angiotensin 1, and this happens in the liver. Okay, and then this is further cleaved. This is a 10 amino acid peptide. Okay, this is becoming an 8 amino acid peptide. 2 amino acids are removed by an enzyme called the angiotensin converting or cleaving enzyme, and this is mostly done in the lungs and partly in the kidney also. Angiotensin 1 to angiotensin 2 is a function of the ACE enzyme, which is there in the tissues, which is there in the circulation, which is predominantly there in the lungs also. Then this angiotensin 2 is the most vasoactive molecule on the whole globe. If at all there is a vasoactive active molecule, it is angiotensin. And there are two receptors, AT1 type of receptors and AT2 type of receptors. AT1 receptors are stimulated, this is vasoconstrictor. If the AT2 receptor stimulated, it's vasodilatory. Angiotensin 2 acts on the AT1 receptors, which are the type 1 angiotensin receptors. AT is angiotensin, T is type 1 receptor, and that produces vasoconstriction. Direct effect is vasoconstriction. In addition, the stimulation of AT1 receptors also stimulates the adrenal cortex. Adrenal cortex glomerulosa is stimulated. That is the outer layer that is stimulated. And that results in aldosterone release, and that goes to the kidney and retains the sodium, excretes the potassium, retains the water, the circulating volume is reduced, renal perfusion pressure is restored. And this directly acts as a vasoconstrictor, and this vasoconstriction also increases the renal perfusion pressure and then decreases the renal. There are two mechanisms. One, by increasing the blood volume through retention of sodium and excretion of potassium and retention of water. The blood volume is increased, renal perfusion pressure is increased. Renal pressure, which was originally decreased, has been brought to normal. By vasoconstriction also, the perfusion pressure, which was reduced to start with, is also brought to normal. 1 second. So this is the mechanism. Now, how does this is important? How does this affect our understanding? Now, this adrenal glomerulosa or the adrenal cortex part which secretes the aldosterone is not under the influence of the pituitary ACTH, unlike the fasciculata, which is under the influence of that and produces glucocorticoids. Mineralocorticoid feedback control is through the juxtaglomerular apparatus, angiotensinogen, angiotensin 1, angiotensin 2, AT1 receptors, vasoconstriction, AT1 receptors acting on the adrenal cortex, glomerulosa, and releasing the aldosterone and increasing the circulating blood volume through retention of sodium and water in the kidney. Okay. Go ahead.
Three cardinal features of primary aldosteronism, that is one, suppression of baseline renin secretion, and second one is inability to stimulate renin secretion normally, and third one is inappropriate and non-suppressible aldosterone production. And coming to first one, the suppression of baseline renin. Primary aldosterone is a state of extracellular fluid volume expansion, especially expansion of the effective arterial volume that results in suppression of renin secretion and consequently decreased generation of angiotensin 2. And second one is inability to stimulate renin secretion normally. That is, the degree of renin suppression by the volume expansion due to the excess mineralocorticoid activity can be quantified by inadequate rise in renin response to common physiological stimuli, that is including upright posture, sodium volume contraction with diuresis or dietary sodium restriction, or the effect of AC enzyme inhibitors. Patients with primary aldosteronism have blunted rise in renin to these stimuli. Coming to third one, inappropriate and non-suppressible aldosteronism production. Aldosterone production in primary aldosteronism is an independent of renin and is relatively non-suppressible despite of volume expansion, inhibition of angiotensin 2 and hypokalemia.
No, so what we have to understand here is there are three things which will clearly point out that a person is having primary hyperaldosteronism. Aldosterone excess. Primary means there is a gland is at fault. Secondary means outside the gland, always. Primary hypothyroidism, thyroid gland is at fault. Secondary hypothyroidism, pituitary is at fault. Primary Cushing's syndrome, adrenal gland is at fault. Cushing's disease, pituitary is at fault. Like that, here primary means adrenal gland is secreting, irrespective of the renin level, it is secreting more and more of aldosterone. What it will do? It will reflexively suppress the renin. So what I will see, there will be a baseline suppression of renin secretion and excess aldosterone in the blood. Second one, now there are certain physiological stimuli which increase the renin secretion. For example, I make the patient stand up, or a sodium and volume, sodium restriction, or volume restriction, or dietary sodium restriction. These effects are normally supposed to produce an increase in the renin activity. That doesn't happen because the renin is suppressed by a very powerful hyperaldosteronism and then excess mineralocorticoid activity, and which is keeping the renin suppressed. The physiological stimuli which increase the renin secretion are unable to wake up the renin and increase the secretion because renin is put to bed and given jolapata by the excess aldosterone because of primary hyperaldosteronism. The third important thing is inappropriate and non-suppressible aldosterone production. Inappropriate means what? When is aldosterone required? When there is volume contraction is there, when the blood pressure is down, when the sodium is low, we require aldosterone. But when blood pressure is high, sodium is high, volume is expanded, but still there is aldosterone. That is what is called inappropriate aldosterone excess. Inappropriate to the environment, milieu. The milieu should stimulate aldosterone, excess aldosterone we should see only when there is renal perfusion pressure is decreased. That means blood volume is decreased, blood pressure is decreased, there is hyponatremia. But in the absence of that also, in the presence of hypernatremia, in the presence of fluid retention, in the presence of volume overload, in the presence of hypertension, they are not supposed to have aldosterone normally. But here we have inappropriately elevated aldosterone in such a condition. So how do I understand that a patient is having primary aldosteronism? One, the baseline renin levels are much lower than normal. Two, physiological stimuli like upright posture, sodium and volume restriction, diuresis, sodium restriction, or ACE inhibitor use is not able to stimulate the renin activity because the renin is put to sleep by excess aldosterone circulating from the primary adrenal problem. Third, there is an inappropriate elevation of aldosterone even when the milieu doesn't warrant it. That means in the presence of hypernatremia, high blood pressure, volume overload, and then fluid retention, we still have lot of aldosterone in the blood, which is inappropriate. You understand? Did you get it?
Yes, sir.
Okay.
Yes, sir. Causes of mineralocorticoid excess, that is primary aldosteronism. One is adrenal cons adenoma, and second one is bilateral micronodular adrenal hyperplasia, and third one is glucocorticoid remediable hyperaldosteronism, that is dexamethasone suppressible hyperaldosteronism. And other causes are syndrome of apparent mineralocorticoid excess, that is same, and Cushing syndrome, glucocorticoid resistance, adrenocortical carcinoma, congenital adrenal hyperplasia, progesterone-induced hypertension, and Riddle syndrome.
Now, what you have to understand here is 99% of the cases are the first three only, first two only. All the remaining are 1%. We are not too much interested to know about same Cushing's causing hyperaldosteronism or glucocorticoid resistance or ACC, adrenal cortical carcinoma, or CAH, or progesterone-induced hypertension, or Liddle syndrome, because their occurrence is very, very low. This is the most common thing. The most common thing is what is described in 1960s by a person called Kohn. This is called the Kohn syndrome or adrenal adenoma. That means there is an adenoma of the adrenal gland involving the glomerulosa, which is secreting excess aldosterone autonomously. That is the commonest. The second one was bilateral micronodular adrenal hyperplasia. Similar to congenital hyperplasia, where the hyperplasia is macronodular and it is in children, bilateral micronodular hyperplasia affects mainly the glomerulosa, and that is around 39%, not 60%. So 60% is cons, 39% is micronodular adrenal hyperplasia, which is bilateral. Naturally, the treatment is going to be medical and not surgical. Whereas when it's adrenal adenoma, the treatment is going to be surgical. And there is one condition called glucocorticoid remediable hyperaldosteronism. Means here it is the ACTH has an influence on the mineralocorticoid secretion. That is dexamethasone suppressible hyperaldosteronism. Because the excess ACTH is there, ACTH is not supposed to do anything with the glomerulosa, but in this condition, there is an internal microenvironment change which makes the glomerulosa amenable for the stimulation by the ACTH. Because CYP11B1 and CYP11B2 gene mutation. CYP11B1 is required for cortisol. B2 is required for aldosterone. So there is a mutation or crossover between these two genes. With the result, ACTH acts to produce adrenal aldosterone. And that is again glucocorticoid remediable hyperaldosteronism. That why it is remediable? You give external dexamethasone, it suppresses the ACTH. ACTH is now producing the excess aldosterone because of the genetic mutation. So that is suppressed. That is called GRH, glucocorticoid remediable hyperaldosteronism, which is very small in proportion. All other conditions like same as a part of Cushing's syndrome, generally we don't have mineralocorticoid excess. Also having mineralocorticoid in a small proportion, glucocorticoid resistance, adrenal cortical carcinoma, ACC, CAH, progesterone-induced hypertension. Liddle syndrome is different. Liddle syndrome is nothing to do with the adrenal gland. Here, there is a mutation of ENAC channels. And these ENAC channels I show you in the diagram, how they are useful for the secretion of aldosterone and then influencing the kidney there to retain sodium and water. Okay, that is Liddle syndrome is a different entity. Okay. So how do I evaluate?
A simplified proposal to maximize detection of primary aldosteronism and implement targeted therapy. When to screen. These includes patient with resistant hypertension that is requiring 4 or more medications to control blood pressure, or uncontrolled blood pressure despite 3 medications. Or next one is severe hypertension, that is blood pressure greater than 150 by 100 mmHg.
There are certain criteria, not that every person will be screened for hyperaldosterone. When you screen, put down these following things. 1, when the patient is young, less than 40 years, and hypertensive. When the young hypertensive comes, you must consider that usually around 15 to 20% of secondary hypertension are due to primary aldosterone. And what is secondary hypertension? Any hypertension which is not controlled by 3 drugs, of which one is a diuretic. The definition is one of the 3 drugs must be a diuretic, given for a period of at least 6 weeks. And then blood pressure is still not responding, that is resistant. Resistant hypertension is a hypertension not responding to conventional treatment in optimal doses of 3 drugs for 6 weeks. Out of the 3 drugs, one is a diuretic. And in spite of salt also being restricted. Patient must have salt restriction, 6 weeks he must have used medicine, 3 drugs should have been used, 1 of them should be a diuretic, still blood pressure not controlled. It is a resistant hypertension, also called secondary hypertension. What are the common causes of secondary hypertension? Renal hypertension, renal vascular hypertension, renal parenchymal hypertension. Renal vascular disease, renal parenchymal disease, polycystic kidney, glomerulonephritis, things like that. The second important is endocrine hypertension. Out of the endocrine hypertension, pheochromocytoma is one important thing. And also hyperaldosteronism is another important thing. So there are around 20% of cases of resistant hypertension can be due to hyperaldosteronism. Normally, if there are 100 patients of hypertension in the elderly, only 5% are secondary. Remaining are essential hypertension, or primary hypertension, or idiopathic hypertension, or metabolic hypertension, or cause unknown, which is 95%. Only 5% are secondary or resistant. But this number of secondary hypertension becomes more when the person is young. So if a young individual presents with hypertension and has been having resistant hypertension, as defined here, and has got hypernatremia and has got a family history and has got an adrenal mass on routine incidental screening, then such a patient is eligible for testing for hyperaldosteronism. Note down these points. Young individual, resistant hypertension, family history of hypertension, and then there is an incidental adrenal. This one is there, adenoma is there, then you are justified in working out. Or the blood pressure is stage 2 or more. That is at least the diastolic more than 100 and systolic more than 150. That is stage 2 hypertension. You can screen. Okay. Yeah, continuing. Actually, you are continuing the same slide.
And hypertension with incidental adrenal mass, and hypertension with atrial fibrillation, and hypokalemia with any blood pressure. And beyond these critical populations, strong consideration should be given to screening all patients with stage 2 hypertension, that is greater than or equal to 140/90, among whom the prevalence of primary aldosteronism syndrome is substantial.
Yeah. Actually, in around 50 years back, nobody considered this as a disease causing hypertension. This is not in the differential diagnosis. None of our professors used to emphasize when you have a hypertension, you must look for primary aldosterone. But in practice, as we grow in the practice in the last 20-30 years, particularly in the young, we are seeing more cases of hypertension due to primary hyperaldosteronism. And if a patient presents persistently with hypokalemia, irrespective of the blood pressure, you must consider hyperaldosteronism. Hypertension with incidental adrenal mass, hypertension with associated atrial fibrillation. Why? Atrial hypertension here is due to AT1 receptor stimulation. AT1 receptor stimulation is a vasoconstrictor and cardio accelerator, and that can produce atrial fibrillation. Hypokalemia, irrespective of the blood pressure, and in all populations who are young, if the blood pressure is stage 2 or more, we should consider screening for primary hyperaldosteronism, because the prevalence or understanding of the disease has changed and the prevalence is increasing because the definitions have changed, the suspicions have changed, physicians' awareness has changed. Okay.
And how to screen? The aldosterone renin ratio is a reasonable and well accepted screening metric. If used, we recommend using an ARR threshold of 20 to maximize for true case detection. However, our preference is to use the individual components of the ARR, that is to evaluate the renin and aldosterone values independently to identify phenotypes suggestive of renin independent aldosterone production.
Yeah. Now here, ARR means aldosterone renin ratio. Okay, A aldosterone, R renin, R is ratio. That means you write aldosterone on the top and renin on the bottom, and then you get the ratio. This ratio should be more than 20. Normally, it will be aldosterone. Whenever there is an increase in the aldosterone, there will be a suppression in the renin, normally also. But here, the aldosterone is so much more that the renin suppression is there. The excess of aldosterone is very much more compared to the suppression of renin, because that is what exactly is ARR more than 20. The authors are suggesting, okay, ARR is an internationally accepted metric, but we would like to look at what is the aldo value and what is the renin value separately, and then can draw some conclusions rather than looking at the ratio alone. That's what is there saying. Evaluate renin and aldosterone values independently to identify the phenotypes, suggesting renin independent aldosterone production. This is renin independent. It is not dependent on the Normally, when you have more aldosterone, when you have excess renin, you must have aldosterone. But in this case, there is independent of renin, there is excess aldosterone, which is the primary hyperaldosteronism. So what do? I do a ARR and also look at the individual values of aldosterone level and the renin level. Okay.
If renin is suppressed, the influence of medication is not sufficient to interfere with diagnostic decision making, and the aldosterone level can be interpreted.
No, 1 second, wait here. What happens is, supposing I use certain hypertensive medications, they themselves suppress the renin. And we have a table also you have put up. So ideally, when you are looking at this ratio, you should stop all the hypertensive drugs. Is it possible? A person coming with 150 by 100 blood pressure or 160 by 110 blood pressure, you stop all the medication. You are risking stroke, and you cannot do it for how many days? At least 4 weeks. You have to stop hypertensive drugs. 4 weeks of and without antihypertensive treatment, we are risking. In such a case, we will try to use drugs like the calcium channel blockers or alpha blockers, which do not have a direct effect on the renin. Unlike the renin-angiotensin enzyme pathway blockers like AC inhibitors or ARBs, better to stop AC inhibitors, ARBs, and also beta blockers and diuretics to control the hypertension. Already this fellow is not controlled even with 4 drugs. So if you stop all the drugs, you will have a lot of problems. So give them enough amount of CCB or alpha blocker, and not, preferably not ACE inhibitor or ARB. Maybe diuretic and beta blocker also should be stopped, because we know these are going to suppress the renin, and our working of ARR will be fault because we have suppressed renin by the drug. We do not know whether it is due to the primary hyperaldosteronism or drug effect. For that, we need to exclude or eliminate the influence of medications which interfere with diagnostic decision making. That is what it meant, that statement. Next, you read.
If renin is not suppressed and the pretest probability for primary aldosteronism is high, a medication washout, that is minimum of 4 weeks, should be considered for mineralocorticoid receptor antagonist and epithelial sodium channel inhibitors, with testing repeated following the washout.
Yes. There are here certain drugs like MR, mineralocorticoid receptor antagonist, spironolactone, amiloride, eplerenone. These are the drugs which act directly on the mineralocorticoid, or epithelial sodium channel blockers also are there. These drugs also should be stopped if there is renin is not suppressed enough, and we expect the renin to be low and aldosterone to be high in primary aldosterone. The renin is over suppressed with BP medications. Renin is not suppressed by these medications. Aldosterone will not be suppressed. So better to stop these, to give a washout period of minimum of 4 weeks. Okay.
And angiotensin converting enzyme inhibitors and angiotensin receptor blockers do not significantly rise renin in true primary aldosteronism. And the use of glyphlozones, that is inhibitors of sodium glucose transport protein 2, can contract intravascular volume and increases renin in normal physiology.
That is what exactly in the previous slide he has put.
Yes, sir.
Sodium channel inhibitors. What are the SGLT2 inhibitors? They also we have to be careful. So what does that mean? When I have to do a testing for hyperaldosteronism, I need to consider what drugs the patient is taking and try and modify or stop or reduce those drugs for a reasonable period before the test is done. There is nothing wrong to do the test. You do the test is very clear, then it's okay. Test is equivocal, then you suppress the drug, stop the drug, repeat it after 4 weeks. Then if you see a very clear picture. Okay. What is this? This is all is the how to screen. Then there are 3 levels they are putting there. How to screen has been okay. So how to screen? The principles of screening have been given, and there are three ways. One is how to exclude, two is how to confirm, and how to optimize. Confirmatory pathway, and then comes the exclusion pathway, then the optimize or enhance the diagnostic pathway. These parts are they have defined. Correct. Simple confirmatory pathway.
Simplified confirmatory pathway, that is suppressed renin is a key biomarker for a population that is enriched for primary aldosteronism and high risk of future cardiovascular events and most likely to respond to mineralocorticoid receptor antagonists. And the ideal representation is plasma renin activity of less than 0.6 nanogram per ml per hour or plasma renin concentration of less than 5 million international units per liter, and liberal threshold values are 1 nanogram per ml per hour and less than 8.2 million international units per liter.
So you have to understand here a little bit of lab. The renin is measured in two ways. One is you can look at the plasma renin concentration, just like serum creatinine and blood sugar. How much of renin is available in the plasma? That is the cutoff value is usually it is less than 5 and the cutoff value is 8 point. Plasma renin activity, plasma renin concentration. The other one is look at the plasma renin activity, and that activity, this is the activity, is the active part of the renin which is available. That is 0.6 is the cutoff, normal value, and 1 nanogram is the cutoff value. Either you measure plasma renin activity, PRA, or you measure PRC. Depending on that, you use the value. Whatever, some labs measure PRA, some labs measure PRC, some labs measure both. So between the two, measurement of plasma renin activity is simpler and widely available.
A plasma aldosterone concentration of greater than 15 nanograms per deciliter should be considered an overtly positive screen. When the pre-test probability for primary aldosteronism is high, example in patient with resistant hypertension and hypokalemia, these results should be interpreted as explanatory confirmatory for the diagnosis. That is, no further diagnostic testing is needed. And the presence of hypokalemia clinches the diagnosis and no further testing is required.
Means what? A person has got hypertension, person has got hypokalemia, already the suspicion of hyperaldosteronism is very high. In such a situation, aldosterone is more than 15 nanograms per deciliter. What more you require? That itself confirms the diagnosis. That's what they're telling. The confirmatory diagnosis is there hypertension? Yes. Is it a young fellow? And is there hypokalemia? And is there an excess of aldosterone, 15 nanograms or more? You don't require to look at the renin, to look at the ARR in such a case. That itself confirms hypokalemia, clinches the diagnosis. Hypokalemia is such an important element in the diagnosis of primary hyperaldosteronism. Exclusion. Confirmatory, you now know. What do? You do renin and renin activity or renin concentration. Renin concentration of 5 or 8.2 is the upper cutoff limit. Usually it is less than 5. And renin activity is 0.6 and cutoff is 0.8. So that is how you look at the renin part. But if a patient presents with hypertension, hypokalemia, and also high aldosterone of more than 15 nanograms, more test is required. You can close the eyes and say, yeah, this is the fellow with hyperaldosterone. Then what is the cause? Commonest cause is adrenal adenoma. Next common cause is bilateral adrenal hyperplasia. So you have to do an imaging to find out the diagnosis. Why? If it is bilateral, treatment is medical. If it is unilateral, treatment is surgical. All other conditions, glucocorticoid, remediable aldosteronism, Cushing's, progesterone-induced hypertension, Liddle syndrome, all are small in number. Same also, you will never get them in your practice because you don't generally do an endocrinology alone. So you don't have to really worry about to differentiate those things. So how do I exclude? Go ahead.
The simplest method to exclude the possibility of primary aldosteronism is the detection of non-suppressed renin, which is incompatible with requisite pathophysiology. And the other pathway to excluding primary aldosteronism is very low aldosterone concentration in the setting of suppressed renin. And the aldosterone and renin should be repeated on the separate day to increase confidence that primary aldosteronism cannot be confidently excluded.
What they are suggesting is, when you have a doubt, if there is if there is a high renin, high aldo, and low renin, there is no problem. We are in a safer zone to diagnose. But if the renin is low and aldosterone is also low, I cannot really say that means primary aldosteronism is very unlikely, and low aldosterone in the setting of the suppressed renin. Both are low, we can almost exclude. The other thing is, simplest method is primary aldosteronism is detection of non-suppressed renin. What is non-suppressed renin? Normally renin should be suppressed by, there are certain mechanisms they have told earlier, like fluid restriction, like whatever are the methods that they have told, you have to use those techniques to see whether the renin is suppressible. That is not possible, then that is it is a pathological requisite for the pathophysiology. And also, aldosterone and renin can be repeated on 2 separate days to get the confidence of excluding the primary aldosterone. So these are for the exclusion. Then, how can I increase equivocal cases will be there? Now there are 3 settings. If it is more than 15 aldo, no problem, you diagnose. Less than 5 aldo, and also renin is also low. Renin is less than 5, less than 0.6 renin activity, or less than 0.5 renin concentration, then you can exclude. But if it is 5 and 15, we are not sure whether it is going to be a case of hyperaldosteronism or not. And such is the case which is being discussed on this slide.
When renin is suppressed but aldosterone levels are neither overtly high or low, that is 5 to 15 nanogram per deciliter, we suggest considering these values as a positive screen for primary aldosteronism. These patients are likely to either have overt primary aldosteronism or a clinically evident phenotype of renin-independent aldosterone production, that is mild primary aldosteronism.
Yeah. So there is a possibility if a patient has got 5 to 15 and when renin is also suppressible, renin suppressed and aldosterone is 5 to 15, then we have to consider this as a positive screen and further work them out to separate them into a sort of equivocal patient or a patient of hyperaldosteronism. Okay.
And these respond to mineralocorticoid receptor antagonists with substantial reduction in blood pressure. And therapy should be recommended for these patients unless they have an estimated GFR rate of less than 30 ml per minute per 1.73 meters square and or hyperkalemia present.
Unless they are stage 3, less than stage 3, that is stage 4 CKD, or they have hyperkalemia, then these people will respond to mineralocorticoid receptor antagonist. It's a substantial reduction in the blood pressure.
Yes.
Now, confirmed primary hyperaldosteronism.
Once primary aldosteronism is confirmed, it is appropriate to guide localization tests, that is cross-sectional imaging and adrenal venous sampling, and for curative unilateral adrenalectomy or medical therapy with mineralocorticoid receptor antagonists and dietary sodium restriction. should be recommended to control and ideally normalize blood pressure, maintaining circulatory potassium in normal range and normalize renin.
Yeah. The idea is you have to keep the potassium should not go down because we know hypokalemia is very dangerous. We have to maintain the circulatory blood pressure and also renin value should be kept normal. So how then we have to find out what is the cause. So we do an imaging of the adrenal and also adrenal venous sampling in the when there is a doubt. And imaging will tell whether it is unilateral, bilateral, unilateral. So adrenalectomy, bilateral, medical therapy with MR receptor, mineralocorticoid receptor, antagonist. Okay.
Pitfalls in the interpretation of screening measurements. That is first reliance only on the ARR ratio rather than the individual components. That is renin and aldosterone can be one of the misinterpretation. The second factor, which is variability in circulating aldosterone levels.
Don't depend only on the ARR. Look at the absolute value of the renin and the aldosterone. And second thing is repeat the aldosterone on multiple days. Don't because there is a biological variability also can be there. That is what exactly he said.
Circulating aldosterone level may vary according to the diurnal variation as well as random peaks and troughs that can be influenced by the factors such as corticotrophin release or stress or diet or posture and timing of medication dosing.
So these are the various other factors which can influence aldosterone, like is he taking any steroids? Is there stress? What is the diet he has taken? What mostly where did he in the walking position, standing position throughout the day? What type of medications he is taking, which suppress and influence the renin axis, and what is the doses of medication? What time he is taking? All these might have a bearing. So you better do the aldosterone on 3 or 4 consecutive days and demonstrate that the aldosterone is really in excess in over a period of time.
Yes, sir. Indications to screen for primary aldosteronism, essential indicators that are severe or resistant hypertension and hypertension with an adrenal mass or an atrial fibrillation or any hypokalemia regardless of blood pressure. Okay. And second one is expanded indications, that is any stage 2 hypertension.
You should understood by now. Patients coming with resistant hypertension, severe hypertension of 150 by 100, hypertension with an adrenal mass, hypertension with atrial fibrillation, any hypokalemia irrespective of the blood pressure, and in stage 2 hypertension, you suspect. And then what you do?
Expand and then measure plasma renin, aldosterone.
Now go to the confirmatory path. Simplified confirmatory path.
That is aldosterone greater than 15 nanogram per deciliter. That is overtly positive screen, or potassium less than 3.5 milliequivalents per liter. If present, that is overt primary aldosteronism.
That means whenever you have high aldosterone of more than 15 nanograms or a persistent hypokalemia of more than 3.5 milliequivalents, you are justified in saying, yeah, this is a case of primary hyperaldosteronism, because we started with these criteria. Patient had hypertension, patient had adrenal mass, or patient had hypokalemia, patient had stage 2 hypertension, and he had a resistant hypertension, plus the adrenal aldosterone is more. We are justified, yeah, we can treat them as aldosterone. Excellent. How do I do that? Then you can access to the specialist, advanced resource and testing is available. Yes, then you refer. If it is not, what do you do? There is no endocrinologist. You are in a primary health center. There is no access for further testing. Later, put them on sodium restriction and MR antagonist. Yeah. Understand?
Yes, sir.
Supposing you have an access to further investigation and endocrinology, you do that. Imaging of the adrenals you do, and adrenal venous sampling you do, AVS is adrenal venous sampling, to determine the potential for curative unilateral adrenalectomy. If unilateral adrenalectomy is bilateral disease, then you have to give MR. If there is no access to imaging or AVS, or it is bilateral, then you go for mineralocorticoid therapy and dietary suppression, dietary sodium restriction. Okay. Now go to the enhanced diagnostic pathway.
Enhanced. That is enhanced diagnostic pathway. That is access to specialists or advanced resources and testing. If present, refer to specialists for aldosterone suppression test. that may be mildly, if marginal suppression is there, that is mild primary aldosteronism likely, or marked suppression.
Now here, what you do is you infuse sodium.
Yes, sir.
Or orally you give sodium. Then what will happen with the higher levels of sodium? The renin must be suppressed. There is a clear failure of suppression. That means the aldosterone is not under the control of the renin. You go to the left side. If there is clear suppression, you exclude aldosterone. If there is a marginal suppression, mild primary aldosteronism likely. Then how do I go about? Again, go to the specialist, yes or no. Then if there is no, go to the MR antagonist and dietary sodium. If yes, go to the adrenal venous sampling and adrenal EEG. Supposing there is marked suppression in sodium infusion or sodium oral or IV sodium infusion, then we know, yeah, this is not an independent aldosterone secretion. The renin axis is being suppressible. That is why it is unlikely. And if you can see, this is an exclusion pathway. But exclusionary pathway.
Yes, sir. If renin is not suppressed, and consider repeat evaluation after cessation of certain medication if applicable.
Yes, if renin is not suppressible, means there are some medications interfering. You stop them and again redo the test.
Or if the
aldosterone is less than 5,
likely negative screen. That is primary aldosteronism unlikely.
Or the renin, there is a marked suppression when we do the renin suppression test, then it is unlikely. Then what do? You follow them with repeat renin and aldosterone evaluation after 3 months. Okay. But if the hypertension is not getting controlled, you put them on MRA treatment.
Yes.
So this is the chapter. Okay. Now go back to your presentation. Yeah. This chart we have seen. It's easier to see on that PDF, so I did that. Now, yeah, these are certain drugs which can influence the renin and aldosterone from the iris, and this table is a very useful table.
Yes. The effects of antihypertensive drugs on the aldosterone renin ratio. That is, in beta blocker, the effect on renin is decreased. There will be decreased renin, and the aldosterone will be increased. So net effect on ARR is increased.
In alpha blockers and alpha sympathomimetic amines have no effect on any of these things.
In ACE inhibitors, the renin will be increased, sir, and aldosterone will be decreased, and the net effect on ARR is decreased.
Correct.
And calcium antagonists also, there is no effect. In diabetics,
telmisartan, valsartan, losartan, these drugs, 81 receptors.
81.
ACEs are ramipril, lisinopril, captopril, all those prils and sartans. They have a similar effect. Either this or that, the effect is same. They increase the renin, they decrease the aldosterone, net ARR is decreased. Calcium channel antagonists have no effect.
And the diuretics, there is a increase in renin and aldosterone. Therefore, net effect will be
maybe neutral or maybe decreased. Doubtful, less effect. So if I want to continue the antihypertensive medication, I should choose something from here, or I should choose something from here, I should choose something from here, and certainly not choose AC or ARB or the beta blockers, because those drugs might have an effect on the estimation of renin and aldosterone and the ARR. That's all you have. It's a beautiful article. I have a few more things to share for you. Very quickly, I will share. So, last time also attendance are not given, I think. That attendance and this attendance, please give. Harrison, he has brought some tables from Harrison, mineralocorticoid excess table, and this is the mineralocorticoid excess paper. This he has brought. You remember that there is a printing mistake here, and this is 39, not 60. That you know. and the remaining things are very small in number, and nothing much. This is again, the same. Here, there is a clinical suspicion of mineralocorticoid excess, severe hypertension, more than 3 pp drugs, drug resistant, one of them are diuretic, hypokalemia, either spontaneous or diuretic induced, adrenal mass, family history of early onset of hypertension, cerebrovascular accident less than 40 years. That means there is a severe hypertension going on. If that is a negative, don't screen. Positive, screen. Measure the renin, aldosterone renin ratio, or current blood pressure medication you stop, spironolactone for 4 weeks, and with hypokalemia corrected, ARR screen positive, ARR more than 7.750 picomoles, is to nanograms per millimoles, aldosterone more than 45 picomoles. That is around 5 here. 5 nanomoles is 455 nanomoles. Then repeat. If the beta blockers are on, you repeat. So if it's negative, exclude. Confirm diagnosis. Saline infusion test you give. This is renin suppression test. Physiological saline or 4-hour IV or oral loading. Or you give a mineralocorticoid itself, fludrocortisone. And then renin is suppressed, then that is important. 24-hour steroid profile you do. Enhance the, once the diagnosis is confirmed, so no CT enhanced, no unenhanced CT you do, unilateral adrenal mass or unilateral adrenalectomy age less than 40. More than 40, surgery is practical and desired, you do. Adrenal venous sampling, you do. Venous sampling, positive, unilateral adrenalectomy. Positive for higher secretion of adrenal, aldosterone. If it is negative, MR treatment. There are only 2 options. MR antagonist, sodium restriction, unilateral. These are only 3 options. Bilateral micronodal hyperplasia, around remaining cases. High in most number of cases, unilateral lateral. 39% of the cases, bilateral micronodal. The treatment is not surgery, only mineralocorticoid. Normal adrenal morphology, then family history of early onset of hypertension, screen for glucocorticoid remediable aldosterone. So it's a very small proportion. If it is positive, suppress bed exercise. If it is negative, give MRA antagonist. Then the 24-hour steroid profile, glucocorticoid by mineralocorticoid is seen, apparent mineralocorticoid excess is there, enzyme deficiency can be suspected, congenital adrenal hyperplasia, adrenal tumor-related ACC, adrenal cancer, or ladies. This is one of the little bit expanded flow chart compared to what we have seen. This is a very useful one also for the other causes. And this table also is shown by our friend. So I have got one more important thing to show you from Davidson. So here you see causes of mineralocorticoid excess. The second, bold one is renin low, aldosterone high, primary hyperaldosteronism. Renin high, aldosterone high, secondary hyperaldosteronism. Renin low, aldosterone also is low, there is an ectopic. So that's how you have to decipher. This table is also very useful. And then clinical features, not this one. So primary hyperaldosteronism, the causes we have seen. The management, of course, only 2 managements. One is the adrenalectomy, and the other one is the MRA drug, amiloride, spironolactone antagonist, or eplerenone. Only problem is these mineralocorticoid drugs have got a gynecomastia in around 20% of patients. That's all we have as far as primary hyperadrenalism is concerned. This article is a nice, useful summary article. All of you can see the simplified confirmatory pathway and also the enhanced diagnostic pathway and an exclusionary pathway. They have divided into that. More importantly, what is very important is you have to increase your suspicion, because today this is one of the important causes of resistant or secondary hypertension based on clinical history of chronic hypertension, hypokalemia. The biochemical testing suggesting a positive screen, the patient was evaluated using enhanced diagnostic pathway. An oral sodium suppression test was conducted and revealed a 24-hour aldosterone secretion of more than 15 micrograms with a concurrent 24-hour urinary sodium excretion of 276 milliequivalent. Aldosterone excretion rate of that much and a sodium balanced diet. So they have confirmed they had a case there. That case they are describing here. So they started with a case, and then that case, how they have evaluated, they have. This also is brought out by our friend. Yeah, this is that case presentation. If the 58-year-old man referred to endocrinology for further evaluation of hypertension and hypokalemia, diagnosed with hypertension when he was 38, but was not treated with medication. 43, blood pressure was 200/100, and then he started on lisinopril. At 50, evaluated in the emergency room and admitted in the hospital more than 3 times for hypertension, urgency, and hypokalemia. Electrocardiograms and echocardiogram confirmed ELV hypertrophy, and 58 years he was treated with lisinopril, nifedipine, carvedilol. Blood pressure is 156. However, the serum potassium is very low, and also 3.1 to 3.4, and bicarbonate is also slightly low. So he was never undergone any evaluation for secondary cause of hypertension. So this is a case which shows that you have to have a secondary cause of hypertension like primary hyperaldosteronism should have been considered very early in the disease. With the result, he would have been treated quite early and not wasted his time. So that's the pointer for eye-opener for all of us. So, okay. Shall we stop here? Any doubts?
Yes, sir.
Please give the attendance for this class and the previous class now.
Okay, sir.
Did you understand how to evaluate?
Yes, sir.
When do you suspect? Who are to be screened? What is confirmatory? What is enhanced confirmation? Enhanced diagnostic technique? How to exclude? So what is the renin suppression test that we do? What are aldosterone, ARR, aldosterone level, then the renin level? What drugs could influence these things in what way? What is the treatment? Bilateral adrenalectomy versus mineralocorticoid. So when to suspect any case of resistant hypertension, particularly in the young, particularly when there is hypokalemia, you should not wait till it is very late. Okay.